Hello, everyone, and welcome to today's Roundtable, Non-invasive versus Invasive Preimplantation Genetic Testing. It's a pleasure to have you all here today for this insightful Roundtable discussion. My name is Dr. Bertie Yunus, and I am the Reproductive Health Market Development Manager at Thermo Fisher Scientific in charge of the EMEA region, and I will be your moderator for this engagement session. Today's educational webinar is presented by LabRoots and brought to you by Thermo Fisher Scientific. We are here to explore the preimplantation genetic testing, and throughout our conversation, we aim to gain a deeper understanding and uncover actionable insights that can benefit all participants. Now, let me introduce you our esteemed panelists, each of whom brings a wealth of our experience and expertise to today's discussion. Dr. Sandrine Chamayou, Laboratory Director in Centro Hera UMR in Italy. Professor Volkan Baltaci, Laboratory Director in Microgen Genetic Diagnosis Center in Turkey. Dr. Anil Biricik, Scientific Director of PGT-IVF Business Unit in Eurofins Genoma in Italy. And Dr. Alok Tomar, Senior Manager, Product Management, leading the reproductive health portfolio at Thermo Fisher Scientific. Welcome, and thank you all for being here with us. Before we begin, we would like to let you know that throughout today's discussion, we have a few poll questions lined up, and where we encourage you to answer to help us tailor our discussion accordingly. A warm-up poll question is already live on your screens, so please take a moment to submit your response. And of course, we encourage you all to participate by submitting any questions you may have for our speakers during this webinar. To do, simply type your question into the Ask Question box and click Send. We will have a live Q&A session at the end of this webinar, where we will try to answer as many questions as the time allows. You may also submit any technical issues you may have in the chat box. And if you have trouble seeing or hearing this presentation, and we will be sure to assist you to have the pleasant experience today by being with us in this webinar. So let's begin. Dr. Chamayou, thank you for being here. Would you like, please, to share with us few information about your experience in your lab?
Thank you. Hello, everybody. Thank you, Dr. Yunus, for this kind of presentation. And I'm happy to be here with all of you today to present, to be part of this webinar. So to introduce myself, I'm Sandrine Chamayou. I'm French, but I live in Italy since a long time ago now. And me and my team perform PGT in Italy exactly in Sicily since the middle of the 90s. Our group was the first in Italy and the second in Europe that applied PGT for beta-thalassemia, because, as you know, beta-thalassemia is a social disease in the Mediterranean area, and especially in Sicily, 6% of the population carry a mutation. In Italy, we had a long story about PGT because it was forbidden between the 2004 and the 2009, but from the 2009, we start again our program of PGT, and our particularity is that we perform all of the procedure of PGT in-house, because we were born first as an infertility clinic. So we perform ICSI, embryo biopsy, and freezing, molecular analysis through NGS, now next generation sequencing. Consequently, we have a complete and constant view of the efficacy of each step of PGT process. And because you know that PGT is a complex and with very articulate protocol, so you need to have a very overview all of the process to give the best result as possible to the patient, to each couples. Nowadays, we apply PGT with NGS not only for beta-thalassemia, but for a very long list of genetic diseases that sometimes are very exclusive of the local population. of course, for chromosomal abnormalities such as translocation, and of course for aneuploidy also when infertile couple requested. We perform PGT in an invasive way. So I will bring you my experience and under this aspect. Thank you.
Thank you, Dr. Chamayou, for being here with us today. Professor Baltaci, now I will address you. Could you please introduce yourself and provide us with some of your experience into your lab?
Thank you, Berthe. Thank you and your organization for inviting me. It's a very pleasure to be here with you tonight. Let me introduce myself first. After my medical education, I completed my specialist program in medical genetics at the same university. Later then, I continued my academic career in this branch. I focused mostly on reproductive genetics and rare diseases. Currently, I serve both at university and in the Microgen laboratory that I found. Microgen was founded in 2000. It is a diagnostic center providing genetic testing services in the field of rare diseases, oncogenetics, and with a special focus on reproductive genetics. With 120 employees, Microgen has a wide range of services in Turkey, with Istanbul and Ankara laboratories. Additionally, we are around establish one branch in Izmir soon. Regarding international status of Microgen, we have a laboratory in Azerbaijan in Baku city, and furthermore, we provide wide range genetic tests, especially preimplantation genetic tests, carrier screening panels, VES and VGS analysis, and some specific panels. Also, comprehensive oncogenic tests in about 35 countries. Microgen is not just a laboratory that provides genetic testing services, but also Microgen has completed a large number of scientific studies, publications, research projects. It has been a partner in different national and international projects, also participated in many validation studies, and coordinate congress courses and some training programs. If I take my second slide, 2 years ago, Microgen moved to its new building with 8,000 square meters of usage area. We provide service in this building with our R&D department, corporate relations, external relations, and other support departments. Additionally, we have an IVF clinic named Genart, biotechnology company named Zeus, and also GMP laboratory named Genetics in the same building. Microgen started PGT-A applications with multicolor fish techniques in 2001 and has applied this method approximately over 14,000 people up to date. Then we moved to comprehensive chromosome testing on embryos with microarray first and NGS technology. Now we have been using NGS technologies since 2015, and currently we perform screening tests over 30,000 embryos every year. Furthermore, we applied more than 3,000 PGTM up to date. During this period, we accumulate very large STR marker pool specific to hundreds regions of genes. However, lately PGTM applications to our laboratory have increased. So we decided to switch more automated methods Therefore, today we focused on applying NGS and SNP-based PGT-M analysis. So microGen laboratory, which has history of 22 years, has realized very important milestones. All these enabled us to become one of the global players. Thank you again for this facility.
Thank you, Professor Baltaci. Thank you for shedding insights to your organization, and we are very happy to have you here today. Dr. Biricik, now I go to you. Could you please provide us some insights on your background and the work happening in your lab?
Thank you very much, Dr. Yunus. My name is Anil Biricik. I am the Scientific Director of IVF PGT Business Unit of Eurofins Genoma Laboratories. Eurofins Genoma Laboratories giving molecular genetic service with different laboratories in Italy, in Milan, Rome, and Modena and Bologna. And now our department is specialized especially on the reproductive genetics as a business unit. And after I received my, let me talk about myself. After I finished my graduate degree in Turkey, I obtained my PhD here in Rome Sapienza University on female reproductive health area. And at the beginning of 2000, I started to work in reproductive genetics area. And at that period, fluorescent instabilization techniques are very popular, and with the day-3 blastomer biopsy and fixing the embryos. And we did many studies on this. And always at the beginning of 2003, different alternative methods for PGT-M, like mini sequencing techniques, has been introduced in the use of PGT applications. And in 2005, our group also completed a preimplantation genetic diagnosis study on HLA genotyping by STR analysis. And especially between 2004 and 2009, due to a specific law here in Italy, as Dr. Chamayou mentioned before, PGD was practically forbidden the embryo biopsy. So we also developed a preconception genetic diagnosis technique for the first polar body analysis, which were giving an opportunity to the couples who were looking for a reproductive solution, which named by reproductive tourism, going to the abroad and other countries. So with this technique, we were able to help the couples for their to reduce their reproductive genetic risk. And also with different applications on structural chromosomal rearrangements by PCR method, we developed, and we did also many different publications on this subject. And at the beginning of 2010, array comparative genetic hybridization techniques introduced in preimplantation genetic testing area, and completely changed the profile of this approach, because with this method, we were able to screen all 24 chromosomes, which were not possible with the previous techniques like FISH techniques. So it was efficiently used and still being used for chromosomal abnormalities and structural chromosomal rearrangements. And in 2014, next generation sequencing technology has been introduced in reproductive genetics applications. And our laboratory was one of the first who did the validation of this technique on blast cleavage stage blastoma samples and trophectoderm samples. And the following years, of course, we applied this technique also for translocation cases by using semiconductor NGS technology. And this technology, of course, brought also the possibility of with high throughput data and the high sensitivity and resolution, also the mosaicism issue. And after the first publication of healthy births in 2015, also we also published many studies. And recently, non-invasive preimplantation genetic testing applications are emerging techniques, and they are very popular, especially with the developments of the technology. Now we saw many publications until now by the using of cell-free DNA and doing aneuploidy testing, especially for analysis of cell-free DNA. And our group also has validated non-invasive PGT protocols, and these studies already presented in recent congresses like ESHRE and PGT-IVF. And today, our group is mainly focused on comprehensive preimplantation genetic testing applications, like together with the copy number variation and the SNP analysis, and especially non-invasive PGT techniques with artificial intelligence, with the cooperation with the integration of artificial intelligence techniques. And we also know that to select the best embryo may not be enough. Also, the environment of the transfer can be important. So endometrial receptivity tests and also endometriomal microbiome analysis are very important. So we have different panels. We are providing also this test. And with the high throughput NGS data, we are now able to do also the different panels for carrier screenings, because the patients, before to start their IVF treatment, they can learn their reproductive risk, and these patients may opt also for PGT for monogenic disorders if they are carrier for some single gene disorders. And recently we have also some other new projects. Genoma is one of the pioneer laboratories for non-invasive prenatal testing, and so we are also now working on a new project with non-invasive prenatal diagnosis, but single cell DNA in maternal plasma. And as you see, we are always going forward with the routine test and the research and development with applications of new techniques. Thank you.
Thank you, Dr. Biricik. Thank you all. Your diverse experience and expertise, of course, will contribute significantly to this discussion today. So let's start. The audience is already seeing a second poll question, so please take some time to answer this poll question, because it will help us direct the conversation throughout this webinar. So I will stay with you, Dr. Biricik, and my first question will go to you. Why is preimplantation genetic testing considered crucial in the context of reproductive health, and what are the potential benefits it offers?
Yes, thank you, Dr. Yunus. Okay, we know that the ultimate goal of in vitro fertilization treatment is to help couples with infertility problems to have healthy births in a short time during their reproductive age. And preimplantation genetic testing is an important tool to reduce the genetic risk of the couples during their IVF treatment and to shorten the time to achieve a healthy pregnancy. Since its first clinical application in early 90s, PGT techniques has drastically evolved, and today we are able to apply PGT for different indications. Preimplantation genetic testing for aneuploidy screening, which named PGT-A, is the most common indication among PGT applications. And the aim of PGT-A is to select chromosomally normal embryos with highest implantation potential before they transfer to the patients. So also recent publication randomized clinical trials showed that the potential benefits of PGT-A, especially for the patients with advanced maternal age, increasing the ongoing pregnancy rate and reducing the miscarriage rate in this patient group. Today, especially trophectoderm biopsy and the 24 chromosome screening by RACGH or and NGS techniques are being considered as a gold standard, and all the applications of PGT-A and the biopsy techniques are very well standardized by the best practice guidelines. Another group for PGT applications is for monogenic disorders, as we know, by PGT-M. The couples at risk to inherit a genetic disorder to their children can get benefit from PGT by selecting only the healthy IVF embryos for transfer to avoid an affected pregnancy risk. And PGT-M can be applied, as you know, with different conditions, with genetic conditions, with autosomal dominant, autosomal recessive, or with X-linked inheritance. And the recent advances in NGS technologies increased also the request for carrier screening tests. So after the detection of the genetic risks of the patients, these couples before to start their IVF treatments, they are the candidates for PGT-M applications to reduce their genetic risk. And in a separate group, PGT can also be applied for HLA genotyping, for instance, in which IVF embryos can be analyzed by their HLA genotype to conceive a healthy baby who may also be potentially HLA identical donor for an affected sibling in need of hematopoietic stem cell transplant. So, as we can see here, other than the diagnostic approach like PGT-M, PGT can also be used for the therapeutic approach for HLA genotyping. Another group who can get benefit for PGT is the patients with who are carrier for structural chromosomal rearrangements like reciprocal translocations, Robertsonian translocations, inversions, or complex chromosomal rearrangements. We know that these patients have increased risk to produce chromosomal abnormal gametes, and as a consequence, increased implantation failure or recurrent miscarriage rates. And the PGT-SR applications allow us to select chromosomally normal or balanced embryos, thus avoid these complications. And again, there are different techniques in PGT-SR applications, but currently, again, the gold standard is being considered basically NGS or RACGH techniques.
Thank you, Dr. Biricik. That was really informative. So, as you know, we have 4 categories into PGT, or why PGT can be done to contribute to a healthy pregnancy and to a live birth. I will stay with you for this for the second question. Can you please then explain for us the difference between invasive and non-invasive PGT?
Yes. As we can understand also from the name, the main difference between two techniques is especially the difference of sampling method. So a standard classical PGT requires a embryo biopsy in different level of in vitro development of the embryo, as currently most of the applications requires the trophectoderm blastomer biopsy, blastocyst level trophectoderm biopsy, which is considered as a gold standard. But still, it is valid to do cleavage stage single or double blastomer biopsy or polar body biopsy before or after fertilization. So these cells, of course, potential DNA sources, which represents the embryo itself and help us to analyze with different techniques, with different indications to detect the chromosomal abnormality or single gene defects on these biopsy samples. When we look at the non-invasive applications, instead there's a big, huge difference that in these applications you don't have to do an embryo biopsy, because the main target is to extract cell-free DNA from the embryo culture medium, or alternatively blastocellular fluid, or both, and using these cell-free DNA molecules for screening test or diagnostic test, which are coming from the embryo. There are still some debates what is the main sources of this cell-free DNA, but the egress of cell-free DNA from the embryo in spent culture medium is not clear yet. But we know that there's a big potential of using this source as a DNA source for detection of different applications, especially for the chromosomal abnormalities. And these sampling methods differences on non-invasive PGT brings many advantages, because first of all, it is not a sophisticated method, so you don't have to need different expertise or instruments to do the embryo biopsy. And also this cell-free DNA also some data is demonstrating that is coming from all part of the embryo, and this creates a big difference with the invasive methods, because invasive methods, the trophectoderm biopsy is basically done because you cannot touch the inner cell mass, but the cell-free DNA is being released from all parts of the embryo, so this may also bring a big advantage for the representativeness of the embryo. And this is another important factor. And from the technical side, I would like to say also there are some differences, because once you use the single blastomer or trophectoderm sample, you have a whole straight genomic DNA for the, I'm just talking also from the molecular biology techniques, what are the differences, because these have an impact on the performance and effectiveness of the use of non-invasive techniques. And you have totally intact DNA, so you can amplify targetedly, or whole genomic amplification, you can amplify your DNA. But in non-invasive techniques, the cell-free DNA, embryonic cell-free DNA is being released into the spent culture media are fragmented and small particles. So this may also, one of the main challenges to use this material as a very valuable this material in an efficient way. And of course, most of the techniques requires for both invasive and non-invasive techniques a total genomic amplification to achieve enough quantity of DNA to be analyzed for the downstream analysis like NGS or PCR or whatever. And these also have an impact for the use correct technique for the amplification, especially for non-invasive applications.
Thank you, Dr. Biricik. This is very informative to explain. So there's a lot of challenge with both invasive and non-invasive, and therefore my next question will go to Professor Baltaci. What is the current, according to you, based on what Dr. Biricik just told us, what is the current level of accuracy and reliability associated with non-invasive PGT method compared to the invasive ones? Let's move over to you, Dr. Chamayou, because I think that Professor Baltaci is having some technical issues. So my next question is for you. What are the common concerns and misconceptions that the patient have regarding both invasive and non-invasive PGT, and how can these concerns be effectively addressed by healthcare professionals?
Thank you. So in general, in our reality, patients are very aware that PGT can test genetic disease on an embryo. Very often we have fertile couples that come because they already had an affected child or a previous pregnancy arrest due to positive prenatal test. So they are candidates, they come to us because they want to undergo a preimplantation genetic diagnosis for a specific genetic disease to avoid abortion. On the opposite, the patients with an karyotype abnormality, with karyotype abnormalities often discover these particularities, this problem while they are completing their exam, their preconceptional exam in our clinic. So they are often shocked and of having an abnormal karyotype, and they have no idea about what is PGT-SR. So in this case, we explain the possibility and the limitation of PGT-SR, and for them it's something absolutely new. Regarding PGT-A, we have more and more often patients and also clinicians are proposed to this patient with advanced maternal age, repeated implantation failure, or recurrent miscarriage to request to perform PGT-A, so invasive PGT-A, I mean. In this case, we take very much care to explain the possibilities and the limitation of PGT for aneuploidy in each cases, in each patient, based on this hypothesis that they didn't obtain a pregnancy because it would have been the embryo to have an aneuploidy, and which are the possibility according to the couple condition. In case of advanced maternal age, it can happen that we explain also to the people that maybe that will not be a so good idea to perform PGT, but instead to try to obtain a pregnancy also without. So regarding PGT, non-invasive PGT, in our area, the patient have no information about it, so we never discuss about this option. And finally, regarding the healthcare professional, we discuss a lot with them, so they are very informed about what we offer to the patients, and according also to the special cases we discuss in Congress or in a private discussion about what are the possibility and which are the protocols. So we try to make the people, the medical personnel, very informed about the possibility of PGT.
Thank you, Dr. Chamayou. I stay with you because it goes in line with what you said. According to you, how the integration of PGT into assisted reproductive techniques improved outcomes for couples struggling with infertility or genetic disorders? Do you see an improvement?
PGT is, I would say, is a reproductive option, especially for the people that have an indication such as karyotype abnormality or genetic disease. So is surely for this patient is surely an important medical breakthrough for those fertile and infertile couples that carry a genetic trait that have a risk of having an affected child. Is a reproductive option because they can they have this valid option to avoid an abortion in case of positive prenatal diagnosis. So it is important for them to have a choice. For those patients who have an abnormality in the karyotype, such as Robertsonian translocation, PGT-IVF also is an important option to bypass infertility, recurrence, miscarriage, and to avoid of having a child with a mental retardation of a physical deficit. For those infertile patients with recurrent implantation failure, repeated miscarriage, or advanced maternal age, PGT-A can be applied, but in this case, as it had been said before, PGT-A is the goal is to avoid the transfer of an aneuploid embryo and to avoid pregnancy failure of having an affected baby. But once again, the application of PGT-A suffers of many controversies that have been lasted since these decades, especially in the case of patients with advanced maternal age, because we know that biopsy is invasive and can have some consequences of the beginning of the pregnancy. There is also the problem of the mosaicism, and sometimes in this case, the trachea themselves that are biopsied analysis and analyzed can have a result that is different from the inner cell mass. So it remains an invasive technique that have to be cared for, and also in the patient with advanced maternal age, because the aneuploidy are mainly due to this age. And the number of oocytes that can be needed to have a haploid embryo can be very high. From our data, for instance, in the patient that are 42 years old, statistically we could need nearly 20 oocytes to have an haploid embryo. So it's clear that it's a technique that can give good results. Nearly 50% of implantation rate when you analyze also the chromosomal aspect, but the biological aspect of the patient is fundamental to have a success.
Thank you so much. I think this is a very clear overview. Genetic test can help to a certain limit, but we should start by also a very important factor, which is the mother and the condition of the mother. In the case, the mother age as well as a limitation factor for any success for IVF cycle. Professor Baltaci, I go now to you. Now we got explained from Dr. Biricik, but Dr. Chamayou also shed some light on invasive versus non-invasive. According to you and the results you have in your lab, what is the current level of accuracy and reliability associated with non-invasive PGT method compared to invasive ones?
Yeah, firstly, sorry the interruption previously, but
no worries.
This is a very important topic. The most crucial point in non-invasive PGT applications regarding the non-invasive PGT applications is to prove whether the non-invasive PGT results is correlated with the standard trophectoderm biopsy material. This is the first important or crucial point. Regarding NI-PGT, two parameters very crucial. The first one is amplification success. The second one is the concordance issue. If we focus the amplification success issue, it means obtaining DNA amplification product in analyzable quality and quantity. This is, I think, the beginning of the problems, very important. Today, almost 100 analyzable amplification products can be obtained from classical trophectoderm biopsy materials. We know that. But if we focus the studies of NI-PGT, non-invasive ones, taken from culture media, especially, I mean non-invasive one from culture media, not blastocell fluid, I think. This is a kind of invasive things. The rate is generally reported as 70% and 90%. It means a little bit lower than the classic ones. If we focus the second crucial point, the concordance issue, the concordance of ploidy status between culture media and trophectoderm material. We need to make clear this issue also. In some studies, concordance ratio reported around 90% on average. In a validation study we performed approximately 2 or 3 years ago, our concordance ratio, if I don't remember wrong, it was 80%. So the interesting thing is, as we know very well, the trophectoderm biopsy does not reflect embryo 100%. This is interesting. Our focus, we matching also non-invasive ones to the trophectoderm, but trophectoderm is not working very well. So especially for PGT-A, due to some biological and technical difficulties, this accuracy not 100%. But if we still checking the accuracy and reliability rates of NI-PGT with trophectoderm biopsy results, actually both presence of only a limited number of cells in trophectoderm biopsy material and the presence of mosaicism are probably the main reason for decreased accuracy, I think. In this sense, testing from cell-free DNA may have a higher potential to overcome these problems, maybe. We need to think about it. But on the contrary, maybe some problems such as maternal DNA contamination from granulosa cells in cell-free technology may cause bigger problems maybe we are sure about that. However, at the end of the day, in order to overcome such kind of problems, an IPGT, regarding the IPGT, it's necessary to make progress on two issues. The first one is collecting cfDNA more efficiently from the culture media. Maybe we can do consecutive embryo washing procedures or more than one sampling from culture media, etc., whatever. The second one is developing new technologies for obtaining a more uniform VGA product. We need to get improvement about that issue also. This is my contribution.
Thank you, Professor Baltaci. Really very good insight towards it. I think we heard the same thing from the three of you, that there is a limitation in invasive and non-invasive. Majorly, the limitation in invasive is if you have mosaicism, so what you are taking is not reflecting the whole embryo. In non-invasive, the major issue could be the contamination that comes from maternal cells or another contamination, and the quality and the quantity of the starting material that we get from cell-free DNA, since the material could be fragmented, and how we do the whole genome amplification. I would like to finish this section with you, Professor Baltaci, and ask you, can you tell us how the PGT testing methods evolved in your lab throughout these years?
Actually, as I mentioned previously, we applied this technology nearly almost 20 years. So we are very beginners one, but in the first, I think, if we focused Louisa Brown, approximately, she was born 45 years ago. Then IVF technologies bring a huge solution for infertile people, but PGT technologies, if we focus the PGT technologies, these technologies brings very important advantage to IVF applications. Then we realized this area very early. Then we started and we focused these technologies. Actually, PGT-A technology is a little bit confused issue because there is no consensus on it. We obtained benefit from PGT-A applications and talking about outputs of IVF. This is very conflict issue, but for this issue we can say that PGT-A shortens the time reach to healthy baby. We can say that. This is actually a common disclosure. And then, you know, the rapid developments in genetic technologies enable PGT applications, brings to some new facilities. These facilities, especially regarding the monogenic disorders. If we focused our clinic nowadays, a very small part of our patients are infertile. The rest of them fertile, but they come to us due to their carriage status of monogenic disorders. So PGT-M is very important. Why? Previously also mentioned, but I need to impress it. First of all, PGT-M protects mother from therapeutic abortion. This is very crucial. Because medical abortion after prenatal diagnosis can cause both physical and psychological traumas to the mother. For this reason, we recommend pre-implantation genetic diagnosis for every carriers for the people with monogenic disorder carriers. The other, I like to tell a little bit more advantage of this technology. Why I want to say that, because all of these bring us to select this technology as our focus. So another advantage is to create HLA-compatible siblings. This is very crucial. The another one is it prevents the transmission of low penetrance hereditary cancer genes to the future generations. Actually, I want to talk about this issue a couple more. I want to mention a study published in 2012. In this study, approximately 950,000 BRCA gene mutation carriers were evaluated. And approximately half of them were around 20 years old or slightly over. It means they are reproductive ages. This is crucial. What I am telling, of course, the risk of risk-reducing surgery can be recommended for this woman, but we know that it is not fully protective for them. The operated patients, because the operated patients have still 4% peritoneal cancer risk. So PGT-M technology has a key role in preventing this residual risk for the future generations, for that families. This is crucial. On the other hand, the issue is Huntington issue, not necessary to explain of it, but during this application, both supposers and third parties do not have to learn genotype of the couple. This is also a huge advantage for PGT-M. There is no this kind of facility regarding prenatal diagnosis. The last one, I want to say, giving priority to transfer to homozygous normal embryos, if any, and the suspension of heterozygous one can prevent the inheritance of the recessive diseases in the next generations. This is, I think, fascinating advantage of PGT-M. And I hope I can explain a little bit ourselves regarding that one.
Thank you, Professor Baltaci. Thank you for the insight. Let's stay on this topic because I like how it's going. So we heard about PGT-A, PGT-M, and we heard why PGT-A is important and why PGT-M is also important. And both of them seems to be answering different questions that the couples are coming and seeking IVF treatment. So let's stay on this to start our roundtable discussion with the question. In the meantime, for the audience, you are going to have other pop-up questions, so please take time to answer those. And let's start with you, Dr. Chamayou, with my question for all of you here in this roundtable. Is non-invasive just limited to PGT-A? Do you see it like this?
PGT-A, no, non-invasive. Of course, you can test which is the DNA that is present inside the non-invasive samples. That can be or blastocell fluid or spent culture medium. And the easier way to do is, of course, to see if there are aneuploidies. And but once again, the problems are from where this DNA is coming from. So if it's coming from an embryo that is doing an ploidy process, so if it's that it was before mosaic and now if it's eliminating is the cells that were aneuploid. And also you can test also genetic disease, but on the so the presence of a mutated allele in these samples. But the problem of this kind of technique, even if the analysis from the spent culture medium are better than compared to the blastocell-free analysis, the problems are the concordance. The concordance is between 80, it can be sometimes higher, but in any case, the concordance seems, even if there are limitations with invasive techniques, they still be better compared to non-invasive techniques. I think the thing that is going out from this present discussion is that we have to explain to the patient that we can transfer also an embryo and we can have a pregnancy from an analysis, from a result of a PGT-A that is invasive or non-invasive, that is not perfect, that is not exactly haploid. That while you don't exist this risk with for a genetic disease, of course, you will never transfer an embryo that have two mutations in case of recessive disease, because you are quite sure that nearly 100% that there will be an affected child. In case of aneuploidy, you have to explain to the couple that you may transfer also an embryo that have an analysis that is not exactly haploid, and you may have a high possibility to have a normal child. So I don't have personally an experience from non-invasive PGT because we practice only invasive, but from literature, I see that there is, you can perform for anything you want, but there still be a limitation greater than in invasive.
Thank you, Dr. Chamayou. Thank you for your insight. Yeah, you make yourself very clear. Dr. Biricik, do you see the same thing as Dr. Chamayou, or you have another light to shed to us here?
Yes, thank you. Actually, yes, partially I agree with her, but my approach will be a little bit different because I think that where there is a DNA molecule, we can do the analysis. So this is clear. So if we have the enough cell-free DNA and clean cell-free DNA, we can apply the non-invasive approaches also for single gene disorder or translocation applications and so on. But there are, of course, the important consensus and standard best practice guidelines and recommendations for the applications of PGT-M, standard invasive PGT-M. So it's standard invasive PGT. So we have to first think about if the conditions and the criteria of non-invasive approaches will fulfill all these standard recommendations for clinical application. And from technical side of view, I would like to separate in two groups. I will evaluate the PGT-M applications and as a singularly, and the PGT-N, PGT-SR separately, because from technically now most common use of non-invasive applications for non-invasive PGT-A for aneuploidy screening, because if you have an efficient DNA amplification from cell-free embryonic DNA with advanced sensitive analysis techniques like next generation sequencing, you can also have as we see also in our studies, we will see also in the literature, and you can have very good profile. I can frankly say that sometimes we get profiles from cell-free DNA better than trophic samples. So this can be also very fascinating. But first of all, technically, you are using whole chromosome screening methodologies for PGT-A and PGT-SR for more or less low-pass NGS strategy. So you don't have to analyze very deep sequencing just to have the aneuploidies, because the chromosomal parts of the NGS technique are very well covered, even in the low-pass applications. But if you talk about in PGT-M, you have to see the genetic changes in nucleotide level. So this is very important So you have to have a good amplification. You have to have also, if you are using NGS, good sequencing read depths to achieve your target in a secure way. And as we know, one of the most important phenomenon is in PGT, even in invasive applications, is allelic dropout or preferential amplification. So if you would like to apply a non-invasive method on cell-free DNA for single gene disorders, you need to have a very robust protocol to cover your target gene, your mutation, but not only, and also the additional informative SNP or STR markers to be sure that you are having correct genetic information from the embryo. The main challenges as maternal contamination or external DNA contamination exist, and this is a big issue for all kind of applications of non-invasive techniques. And if you look at the PGT-SR, like structural chromosomal rearrangements, I can find it easily to apply, because if you look at the literature, there are some publications for PGTM on non-invasive technique, right? Like targeted fluorescent PCR techniques just for sex chromosome determination, or even some studies for b-thalassemia, single mutations. But if you look at the details, you can say that it is really difficult to fulfill the standard recommendations for PGTA. So you have to amplify efficiently your zone of interest. You have to also informative SNP or STR markers to be sure that there is no allelic dropout or recombination event that may affect your diagnostic approach. For PGT-SR, non-invasive applications can be much more, I think, promising, because if you have a good technique for aneuploidy screening, you can also detect the not only full aneuploidies, but also segmental abnormalities by cell-free DNA analysis. But of course, there are always remaining the standard limitations of PGT-SR applications, like the resolution of your test, so how many megabases of chromosomal segmental changes you can detect, and these are the common issues. But I think on a very good standardized protocols, I don't see many, at least in the next future, I don't see many obstacles also for the applications of non-invasive techniques for these areas.
Thank you, Dr. Biricik. Professor Baltaci, now to you. Do you agree with what Dr. Chamayou and Dr. Biricik stated regarding invasive, non-invasive for the different types of PGTs that you see every day in your lab?
Yeah. Firstly, it's necessary to say that, of course, the non-invasive PGT is not limited to PGTA. It's theoretically. But if we focus the practical issues, the non-invasive PGT-M and non-invasive PGT-SR a little bit problematical, according to me. Because the exact problem is the DNA sample is not uniform. Regarding the all classical PGT applications, all of us are focusing the pitfalls of that technology, you know. If we focus the pitfalls, all of them directly related with the DNA quality and quantity. This is the origin of the problem. So we need to think about on this issue. So let's go again PGT-M, SR, or A applications via non-invasive cell-free DNA methods. If you focus the PGT-M, we need to get enough quality DNA regarding the mutated region of the DNA of the patient. If our DNA is not suitable regarding that area, if we have a huge, wonderful technology even, we can't get a reliable results. So PGT-M issue depends this point, but if we focus the PGT-SR, this time the region is a little bit bigger than the M1. So I agree with Dr. Anil with that point. I am believing this SR regarding the SR issue, an IPGT will work in reliable conditions. Of course, the PGT-A issue, we also will get reliable results regarding that one. But I can say that an IPGT technology for PGT-A today, for PGT-M tomorrow, I think.
Thank you, Professor Baltaci. Thank you, all of you, for this very informative roundtable. Now let's move to the next session. In the meantime, your audience, please, you will have some poll questions also, so be sure to answer them. As we heard many times during today's webinar, we heard a lot that NGS is becoming a standard model, a standard technique when we talk about PGT. And the PGT market is more and more moving towards NGS. So we have today Dr. Tomar. Thank you for being with us. Could you please shed some light on how can Thermo Fisher Scientific portfolio support PGT research?
Thank you, Berthe. Yeah, sure. So I am going to go over a few slides that are going to talk about the most relevant offering, right, for this particular topic. Just a quick introduction. I'm Alok Tomar. I'm Global Product Manager managing reproductive health portfolio at Thermo Fisher. I'm based in Carlsbad, California. It's a little coastal community in the greater San Diego area. So, talking about NGS, for the last decade or so, right, NGS has been a technique of choice for PGT analysis. The simple reason being that, NGS does offer a versatile, sensitive, and high throughput method of PGT screening. Thermo Fisher has been leading the way with the ReproSeq technology that's been on market for a few years. And what that particular assay allows our customers to do really is, right, it allows them to use the low-pass whole genome sequencing to identify a variety of genetic abnormalities, even with small amount of DNA. We all learned how, the starting material is a limitation in this particular field. What we also know that, with the particular test that we have, customers can easily analyze a normal and abnormal samples. An example of normal sample would be an euploid sample where chromosomes are intact. So 46 chromosomes can be analyzed easily, and abnormalities can arise because of whole chromosomal aneuploidy, segmental aneuploidy, and mosaicism. The ReproSeq PGS kit, right, does allow customers to have an end-to-end solution. So there are reagents, there are software that allow you to generate reports, like you can see here. The reports are also very visual in nature, easier to understand. In this particular example report, you're seeing aneuploidy section being highlighted with a graphical representation. There is a mosaicism detection, which can also be done graphically. The report allows our customer to provide a report with a gender revealed or gender masked. And on top of that, right, we have a wealth of information on our websites, on our other materials that give in-depth access to how to use these different tools and how to adopt this product easily within your own labs. So the low-pass whole genome sequencing was great for PGT analysis with our ReproSeq product, but we did want to offer additional capabilities to our customers. So we recently launched a polyploidy panel. With this particular SNP-based polyploidy panel, it opens up the opportunity to do even more for PGT and provide a comprehensive PGT experience, right? So SNPs are genetic variations that happen within the population. And with this SNP-based panel, customers can now look at the ploidy status. They can determine maternal contamination and perform a sibling QC to ensure there are no sample mix-ups in the lab. So how does the polyploidy assay help our customer, right? So I think there are three key areas that this assay helps, in terms of tackling the current challenges in the field. One is triploidy detection. So it is known that with the traditional PGTA plots, the 69XXX females are extremely hard to determine, right, from traditional PGTA plots. But with the SNP-based analysis, now this determination can be made confidently as well. This also allows, contamination risk assessment. So with traditional PGTA biopsy samples, the cumulus cells can contaminate the embryo biopsy sample. But with this SNP-based PGT analysis, you can determine the level of contamination present. And then again, more importantly, right, a lab does get hundreds of embryo biopsy sample. There is a potential that the samples can get mixed up. But with this polyploidy, now customers can establish a DNA fingerprinting, if you will, of those samples, which really prevents that kind of sample mix-up in the lab, giving additional peace of mind. So how does the workflow look like of doing both the assays together, right? PGTA as well as polyploidy. So the embryo biopsy samples are precious. We have that limited starting material. The workflow that we have developed, right, enables lab to do both with the same sample. They can use the ion single-seq technology and do the PGT analysis with a reproductive kit, and they can use on the same sample, the AmpliSeq technology and run the polyploidy assay as well. So that really enables them to maximize the sample that they have in the lab, but provide a comprehensive PGT reports to their own clients. So in terms of platform, we have two exciting choices for our customers to choose. We offer the integrated GenAccess system. This is a floor model that has combined the templating, sequencing, and reporting all in one model. So it saves space, and it's a more comprehensive sort of a walk-away system. But we also have, our time-tested Gene Studio system. Here, customer would need a separate instrument for templating, which is the Chef, and then a sequencer, which is the Gene Studio itself. Within the Gene Studio, there is a different capabilities that customers can get depending upon what kind of menu they want to have in their lab. So all in all, right, two great systems to choose from that can get the lab started with whatever their current needs might be. So finally, right, so next generation technologies are empowering next generation decisions in this important field. We all know that infertility affects millions of people worldwide, and this really makes this a global health issue. And PGTA, as we heard today, right, can increase the success of future pregnancies and ensure that, there are, healthier pregnancies, which is impacting our next generation as well. And with the polyploidy assay, the ability to do sibling QC and ability to determine more with the precious embryo biopsy sample, it really enables customer to do a more comprehensive testing and serve their clients even better. So that was my final slide per se. Thank you for this opportunity, and happy to take any questions that the audience might have.
Thank you, Dr. Tomar. At the moment, some more questions will pop up for the audience, so please take some time to submit your answers to the poll. And we come to the last part of our webinar today, which is the Q&A live questions. So we already received a lot of questions. I will try to select one per presenter due to the time. The first question is for you, Dr. Chamayou. In the context of invasive PGT methods, what advancement has been made recently, and how do these techniques contribute to our understanding of genetic disorders in embryo?
Thank you for your question. It's clear that from the very beginning, pre-implantation genetic testing that was before named diagnoses have made huge progress since that we start to work on the 8-cell stage with PCR of fish and transferring the diagnosed embryo on the cell on the same cycle than when it was opus and oocyte pickup. So now inside the IVF lab, there have been a lot of progress regarding the embryo culture and vitrification. But one of the clue points has been the next generation sequencing. That was really a revolution in the field of the diagnosis, in the testing. That now any genetic trait can be diagnosed inside an embryo once it's known. You really can follow with the SNPs the possibility to follow. You can follow each allele from the maternal or paternal sample, and you can also test on the same sample the genetic aspect and the chromosomal aspect. On the other side, and this was really a revolution that now gives us the possibility to have a huge knowledge about the embryo, not only on the genetic disease, but on the embryo in general. On the other field, on the field of the embryology, it's shown, that's why also we now think about non-invasive diagnosis. What is the limitation of the embryo biopsy, the trifecta themselves, that is not always the true image of what the embryo will become in the inner cell maze. So next generation sequencing give us a very deep knowledge about the genetic, about the information, DNA data, and not only about the embryo, and give us also a lot of information of the perspective and the limitation of the PGT in general.
Thank you. Dr. Chamayou, the next question, I think it's for you, Professor Baltaci. How might advancement in artificial intelligence and machine learning impact the analysis and interpretation of genetic data obtained throughout PGT technique?
Actually, this area is very attractive, and we have huge hopes regarding that one. If we focus the invasive PGT-A methodology and AI technology, regarding this issue, the biggest expected contribution is the elimination of background that has a negative impact on the results. This is the issue. Actually, a commercial software on this subject has been developed by a company a couple of years ago. Actually, we get the chance to try it, but we didn't find it effective. However, at this point, actually, there is no validated and effective AI solution regarding that issue. But regarding your question, if you focus the NIPGT part, it seems that artificial intelligence technologies will play an important role in detecting embryos with higher implantation potential, combining embryological images with the clinical parameters. Some of the studies performed on this subject aim to associate time-lapse images with the positive pregnancy result. But according to me, the more accurate option is to correlate time-lapse images with the ploidy status or genetic status of the embryo, because ploidy status is a kind of quantitative data, and this data is more suitable for AI algorithm, but the clinical pregnancy is not a positive data. It's multifactorial things, so it's not suitable for AI algorithm. Additionally, there are some studies, that include clinical parameters such as age and anti-Mullerian level or FSH level or body mass index, something like that, to increase predictive value of AI. I think it can be developed issue. As a result, NIPGT or more suitable definition, AI-based ploidy prediction has a big potential to improve pregnancy rates and reduce the cost of IVFs due to classical PGT applications or biopsy procedures.
Thank you, Professor Baltaci, for shedding light on that. That is, in fact, a very interesting subject now and a hot topic, artificial intelligence used in PGT. My next question goes to you, Dr. Biricik. Could you please outline the advantage and limitation associated with non-invasive PGT? I believe we heard some of you during this today during this webinar. And how do these factors influence the decision-making process for patients and healthcare providers?
Yes, actually, this question will be a summary of more or less we discussed during the webinar, but it's a good opportunity to summarize them, and maybe we can also focus these factors. If we start with the advantages of non-invasive PGT, is first of all, it is obviously less detrimental because you don't touch the embryo, and this is a very good advantage that you don't have to potentially damage the embryo. We know that the standard biopsy procedures are very well standardized, and the trophectoderm cells are not involving the embryo development, so trophectoderm biopsy is being considered very secure and very, very correct technique. But if you use non-invasive approaches without touching embryo, of course, this is also less detrimental. And also, this non-invasive approach bring another advantage, like especially if you can apply in different IVF laboratories, if they don't have any possibility to do the embryo biopsy and to give this opportunity to their patients just to have the genetic information from the embryos because of the absence of technological devices or like micromanipulators, the biopsy systems, or if they don't have expertise to do the embryo biopsy, this can be also a good advantage. And even if some IVF centers, maybe they have a good experience for the PGT, for the invasive techniques, but in some bad responder patients, very bad morphology embryos, if these embryos, they don't allow to do embryo biopsy, then they have to do only, of course, if they have the different embryos, they have to select by the morphological criteria. But in that case, if you are a very good optimized non-invasive PGT protocol, then you can give also the opportunity to have the genetic data of the embryo and to select a potentially euploid embryo and to give this possibility to the patients. And in that case, of course, most of the PGT applications are being considered as a screening test because, as we know, again, the gold standard is the invasive PGT, but non-invasive approach can be used as a prioritization of the embryo, as a ranking system, and just explaining to the healthcare professionals and the patients the potential risks and the limitations of the test, but can give an prioritization for the embryo transfer. And especially other than morphological assessment, if in some countries, especially where there are legal issues for the embryo biopsy or the application of preimplantation genetic testing, non-invasive approaches can be a very good opportunity for these countries, and they can also give this possibility to their patients and without touching the embryo. So this is a good advantage. But of course, like all new techniques, and especially as we discussed many times, and there are some limits of PGT, non-invasive PGT application. And today, it can be used only a prioritization approach, and it's a screening test, and yet it cannot be replaced with the standard invasive technique with embryo biopsy. And if we look at also the effectiveness and of this approach in the literature, and there are the main studies are based on the concordance analysis between trophectoderm biopsy and the cell-free DNA, the concordance. But from this point of view, I think we have some limited data because trophectoderm biopsy is being considered gold standard, but as we know, in the future, the gold standard may change because trophectoderm biopsy giving us a limited genetic data from the embryo, and the same issue cannot be resolved. And so in that case, maybe we should also consider that this factor as well. And many of these concordance analysis studies, as we can see that there's a different range of concordance from starting from 40, 50% until 90%, but each group for each laboratory, they have basically used their own validation systems. But if we see these results, we can understand that there is also standardization problem of the techniques, so there is no any standardization. So this also should be overcome before to put this technique in clinical use. And from embryology side of view, there are some other limits, like embryo laboratories, they have to also adapt their routine practice to non-invasive applications. For example, culture media volume or the environment of the embryology laboratory to avoid the contamination, or during the IVF treatment, for instance, the denudation of the oocytes, or culture media change just to avoid the apoptotic cells or other maternal contamination, and culture media extension until, because we know that all data showing us that the late embryo development giving us much more concordant data. So the culture, embryo culture also should be expanded until preferably day 6 or even day 7. These may have some difficulties for the embryo laboratory. But if you can think about all the advantage, and once also with the new techniques and the new laboratory devices, if these problems should be overcome, then also I think that for the embryology laboratory, it will be advantageous to modify their practice protocols and adapt them to the non-invasive approaches. And of course, we know that now most popular non-invasive evaluation is like morphokinetic analysis, or with the now recent artificial intelligence algorithms. This method also has been used very effectively, but I think that integration of the genetic data and also some other information like patient history, ovarian stimulation protocols, or many other factors together with cell-free DNA data and the morphokinetics can give much more information, because with the computing technology we have today, we have a huge data, and we know how to classify all these data in an effective way. And this will also increase the robustness of non-invasive applications.
Thank you, Dr. Biricik. This is a very nice summary for all this presentation in just light of the time now. I am really happy to have this conversation with you. My last question that we should go quickly to it, Dr. Tomar, is for you. Is the ReproSeq kit meant to be used with both invasive and non-invasive PGT-A? Is there any challenges associated of using this kit with non-invasive PGT-A?
Yeah. So I think ReproSeq has been used with invasive PGT-A for a long time, right? So I don't think I need to probably answer that question. Simple answer is yes. You get really great results when you have a good quality sample that's not as contaminated. So ReproSeq works absolutely beautifully with invasive PGT-A. With non-invasive PGT also, right, we do have our customers using it and getting really good results. But with non-invasive PGT-A, the most important things to remember, and as all the panelists discuss this in detail, right, the sample quality and quantity really matters. If you get a decent amount of DNA, which is not as contaminated, fragmented, obviously the chemistry of ReproSeq works really well, right, for non-invasive as well. But what is important is to really establish good SOPs when you are getting samples from the IVF labs, having checks and balances on the starting material, coming up with a protocol, right, that's appropriate for non-invasive PGT-A with appropriate checks and balances of looking at your starting material. But if all of those are optimized, and we do have some customers that have optimized it quite well, the kit works really well for non-invasive PGT-A as well. But I think you are on mute. So, but if you're trying to say something, we can't hear you. Just a heads up.
It appears that Bertha is having some issues with her mute, but we do want to thank all of you for joining us today. We want to thank you, Dr. Chamayou, Dr. Baltaci, Dr. Biricik, and Dr. Tomar for your time today. I'm sorry, Professor Baltaci, for your time today and for your insightful discussion. We also want to thank LabRoots for hosting today's webinar in our platform, and we do want to thank our sponsor, Thermo Fisher Scientific, for sponsoring today's webinar. Thank you all for joining us today and for your interesting questions. LabRoots will alert you via email when today's webinar will be available to be viewed on demand. We encourage you to share that email with your colleagues who may have missed today's live webinar. Thank you, everyone, for joining us, and have a wonderful day.
Thank you.
Thank you.
Thank you.
Thank you, Bertha. Thank you, all of you.
Thank you. Bye-bye. Bertha, sorry, I don't know what happened to your mic.